We are going to talk a lot about sex today. My name is Ashley Manta. I'm better known as the Canisexual. I have been a sexuality educator for 11 years. I got my start as a sexual and relationship violence prevention educator, a rape crisis counselor, and a victim advocate. And that's really what I'm here to talk to you about, is how you can be these incredible ambassadors out into the world to give people permission to have joy and pleasure in their lives when they're looking to you, because you are the knowledge keepers of the body and how it works. Did anyone actually have any kind of pleasure-focused genital education in their nursing education? Not even a little? Okay, awesome. This is a vulva. To quote the Lion King, you ready? Everything the light touches, Simba. That is the vulva. There is more than just what you see right here. And medical science was blissfully ignorant of this fact until 1994. Right? Exactly. It's like the endocannabinoid system. It's been there all along, but no one was looking for it. Not now. Not here and now. Keep your pants on, folks. This is not that kind of conference.
It's my pleasure to introduce the first speaker for the afternoon, and this is someone who will really get us started the right way, because she will be talking about cannabinoid-assisted intimacy. Yeah, absolutely, and it is a powerful and stimulating presentation. Ashley Manta is a professional sex educator and coach. She helps people navigate these topics to make sure they are interacting, loving, and feeling their best in and out of the bedroom. Her work has been profiled in the Huffington Post and referenced in the London Times, Newsweek, BBC Three, and LA Weekly. We are so proud to introduce to you today as our speaker, Ashley Manta.
Good afternoon, everyone. I would really love it if we could all just take a deep breath together and kind of land, come back, be present. So everybody take a deep breath and exhale with some sound. Awesome. It does sound sexual, and we are going to talk a lot about sex today. My name is Ashley Manta. I'm better known as the Canisexual. So how many people are meeting me for the first time? Most of you. Hi! I'm so happy to meet you. I'm so thrilled to be here. How many people have met me before, interacted with me at other events? A couple folks. Amazing. It's great to see you again. I have been a sexuality educator for 11 years. I got my start as a sexual and relationship violence prevention educator, a rape crisis counselor, and a victim advocate. So I would work with clients who had been recently sexually assaulted. I would go to the hospital with them and sit with them through their forensic evidence collection examination. I would sit with them through their conversations with police officers at the police station. I would sit with them when they would go to court for their preliminary hearings. And so I really got to understand what it's like for a victim to go through the medical and criminal justice process. I myself am also a sexual assault survivor. I was sexually assaulted when I was 13 years old. I was molested as a child, and then I was raped 2 more times after college and grad school. And one of those times ended up with me having genital herpes. And so I speak very openly about living as a sexual assault survivor, living with genital herpes, that it's not a big deal. It's really not. You as nurses know that it's not a big deal. But there's so much fear and stigma out in the world about bodies, about trauma, about illnesses and infections, and there's so much misinformation and fear. And so you, as nurses, have such a powerful opportunity to be the voice of reason and clarity and understanding and compassion. And that's really what I'm here to talk to you about, is how you can be these incredible ambassadors out into the world to give people permission to have joy and pleasure in their lives when they're looking to you, because you are the knowledge keepers of the body and how it works. And people are so confused by how bodies work. All they have really to go on is porn. And how many people have ever seen porn at some point in their lives? Once or twice. Porn is great. I'm a fan. Some of my dearest friends are porn performers. I love it. The problem is, it is not sex education. That would be like watching The Fast and the Furious to learn how to drive. Probably not going to end well for anybody. And so I want to start with all of you with actually just a little bit of pleasure-based anatomy, because I'm willing to bet that in nursing school, they didn't cover genitals from a pleasure perspective. They probably covered them from a reproductive perspective, from a medical perspective with, the urinary system and the kidneys and all of that and how it all works, but probably not a lot about how to make them feel good, right? True. Did anyone actually have any kind of pleasure-focused genital education in their nursing education? Not even a little? Okay, awesome. There you go. So let's start with the most useful piece of information that I can give you. Well, one of the two most useful pieces of information I can give you. What is this? This is a vulva. I have had people my whole life, ever since I bought this puppet, be like, "You have a vagina." And I'm like, well, that's one of the things I'm holding. Not all of them, though. You wouldn't refer to your face as your throat, but for some reason, we call this the vagina, even though that's just one part of it. To quote the Lion King, you ready? "Everything the light touches, Simba, that is the vulva." You're welcome for ruining Disney. Everybody take a deep breath. We're going to do that a couple times throughout this whole little talk that we have together, because talking about sex can be really challenging. And if it's challenging for us, if you're sitting there and you're a little shaky that we're talking about this right now, imagine how it is for your patients. When maybe no one has ever spoken to them about their body in an affirming, positive way before. The situation that we grow up in our society, is so sex negative. It's so shaming. It's so abstinence only. Sex is bad. You're going to get pregnant and get diseases, and things are awful, and pain, lots of pain. And there's trauma, and we don't talk about that either. And so we have these folks hopping from one foot to the other, trying to figure out what to do and how to make themselves feel good, and suddenly they turn 18 and they're just expected to have all of this knowledge downloaded into their brains. And it doesn't work that way. And so I'm so excited to share with you things like vulva versus vagina, so that we can start to have these conversations in a really real way, in a medically accurate way, and also in a compassionate and kind and permissive way. So the other most important thing I'm about to tell you about pleasure-based anatomy, besides the fact that this is a vulva, is that the clitoris, which some of you may recognize right here, and look familiar to anybody? Seen it once or twice, I hope? Have you seen your own? Because I'm just saying, if you have not actually taken out a hand mirror, please do that. Not now. Not here and now. Keep your pants on, folks. This is not that kind of conference. However, if you do want to have that experience, please reach out to me because I do facilitate those experiences for people. I'm in the process of getting certified as a body sex facilitator through Betty Dodson. And if you don't know who Betty Dodson is, she's someone you want to look up. She's almost 90 years old and has been teaching people with vulvas how to feel pleasure in their bodies since the late 60s. She's a rock star. And what I learned from her and from others is that in addition to what you see here with the clitoris, the clit has legs. There is more than just what you see right here. And medical science was blissfully ignorant of this fact until 1994. Right? Exactly. It's like the endocannabinoid system. It's been there all along, but no one was looking for it. So this is going to be hard for you all to see, but hopefully our dear friend behind the camera will be able to zoom in for playbacks. This is the entire clitoral complex. It has legs. It's bigger on the inside. It's like a TARDIS. Thank you, Doctor Who fans. What you see on the outside is just the very tip. It would be like if you could only see the glands of the penis and you thought that that was all there was. There's so much more. And you know that the penis extends another few inches into the body, right? Cool. If you didn't, now you do. If you're missing that during hand jobs and oral, talk to me. I do classes on those too. But the clit has 8,000 nerve endings. That is double the amount of a circumcised penis. And I specify circumcised penis because an uncircumcised penis, the foreskin, contains 20,000 nerve endings. So when we are circumcising babies, we're taking away 20,000 nerve endings of pleasure in their penises. That's a lot. So 8,000 nerve endings, and it's mostly on the inside. And where this becomes relevant to cannabis is because people think that the clit is all there is, and so they get real fixated on this one little spot. And how many people have ever heard patients, we'll pretend it was a patient told you that they got hyperstimulated from too much focus on the clit. Anyone experience that? Perhaps maybe experience it in your own life. Gets a little sensitive and you're like, nope, not anymore. Been there? Yeah, that happens. That happens, that's real. If you remember that the clit has way more real estate on the inside, and it actually comes back in a shaft, so above the hood of the clit, there's a shaft, so you can kind of rub that back and forth. It also goes down between the inner and outer labia. And inside of the legs are these two things called vestibular bulbs. Anyone heard of the vestibular bulbs before? No? How is this possible? I need to have a conversation with more nurses because y'all are amazing, and I'm so grateful for what you do, and I'm so happy to be able to give you more information that you can pass on to your folks, because this is huge stuff. So the vestibular bulbs and the clitoral legs, it's the same erectile tissue as the penis. So when the penis becomes aroused, it sometimes becomes erect. We've seen this happen, maybe once or twice, okay? The clit also gets an erection. It swells, the legs swell, the vestibular bulbs swell, and these hug the opening of the vagina, which causes more pleasure when penetration is happening. Now, there's something that's really important to know about pleasure and arousal, and that is the concept of something called arousal non-concordance. And what that means is that sometimes when you see something that would typically turn you on, that your brain would code as a sexually relevant stimuli, in people with vulvas, that only coincides with arousal, wetness, feeling turned on 10% of the time. Just 10%. Penises have a little bit more. They get 50% of the time. So it's literally half and half whether a penis gets erect when it sees sexually relevant stimuli. But in vulvas, it's only 10%. And so if you have patients coming in and they're like, I'm not getting wet, before you reach for the prescription pad, before you start pathologizing their sexuality, you have the opportunity to tell them that wetness does not always equal arousal. And that could be the thing that changes the game for them. That could be the thing that makes them feel like, oh my God, I'm not broken. There's nothing wrong with me. I just need lube. I just need more warm-up. I just need to create context for me to get turned on in. Because that's what our brains need. We need context. Arousal and desire are a very complicated system and network, and there are so many factors at play, that from physiologically to mentally and emotionally to spiritually and like where they are in their cycles. It's all related to how you get turned on. And there's so much more to it than I like you, you like me, let's go into the bedroom and take our clothes off and like make things happen. There's a lot more to the story. Everybody take a deep breath. Now, I could go into the pleasure-based anatomy of the penis, but we hear about penises a lot, and I feel like they can have their own time another time, but the vulva is the thing that seems to still be shrouded in mystery, despite the fact that it's 2019. So how many people were really surprised when I told you that the clit had legs? Right? Now, are you going to go home and experiment and try all sorts of new things? Because I think you should. That would be excellent. So what I really want to create space for in this conversation is the importance of checking your assumptions at the door when a patient comes to you to talk about sex. Don't assume that they're straight. Don't assume that they want kids. Don't assume that they're in a committed relationship. Don't assume that they're monogamous. Like, go in tabula rasa, complete blank slate, and let them give you information. Create space to be like, hey, tell me about your life. Tell me about your sex life as you define it. Tell me about your partners. Say partners instead of boyfriend or husband. You know, don't assume that because someone presents feminine that they have a vulva. You know, we've become so much more aware of trans and non-binary identities and bodies, and that's such an important thing because not everyone is a cisgender human. And you're gonna see those folks, and it's gonna be wonderful when you are like, oh, cool, so what are your pronouns? As opposed to assuming that because you look like me, that I'm a she. And so really letting the patient kind of have the opportunity to talk about these things in a space that's non-judgmental, that's non-stigmatizing. You know, bodies are more than just a vehicle for disease. You all know that. There are brains and hearts and minds and things, the ways that we interact with each other and the ways in which shame and stigma can really damage us from an emotional to even a cellular level. And there are things to consider around ability, ethnicity. As a white woman, I have a lot of privilege moving through the world, sexually and generally. And so thinking about those things and intergenerational trauma, and there are so many factors that go into how people show up in the world sexually. And we have to be aware of them. We have to be aware of our privileges and biases and the ways in which we think that it should be a certain way, so we just assume that everyone's like that. And one of the big things that happens is that people assume that sex is a very linear trajectory. That sex, what is sex? Penetration, intercourse? That's awfully limiting. Sex is really just one or more people sharing space, co-creating pleasurable experiences. And if we use that as our definition for sex, instead of, my penis doesn't work, it doesn't get hard, so I can't have sex, well, you get to say, but wait a minute. It's still there, the nerves are still there, it still functions as a vehicle for pleasure. You just may not be able to access that pleasure in the ways that you think that you should. Maybe your partner just doesn't get turned on and doesn't want to have intercourse, but they really want to make out. They really just want to be held and like stroked lovingly. And to be able to give folks ideas of thinking outside of this very linear box that we put sex into, instead of immediately reaching for a prescription, instead of immediately reaching for like, oh, you're broken, you need to be fixed. maybe what really needs to be fixed is our mindset. And that is where cannabis comes in. You guys are like, why are you talking about this at a cannabis conference? Here's why. Glad you asked. Before I actually get into that, I want to tell you about these two systems in the brain. There is what's called the sexual excitation system and the sexual inhibition system. Anyone heard of these before? It's called the dual control model of sexuality. Dr. Emily Nagoski, who is a PhD sexuality researcher out of University of Indiana, is an amazing, amazing authority on this topic. And she wrote a book called Come As You Are, which I think everyone should read for their own knowledge and edification and also for their patients. And what she does is she talks about these two systems, the sexual excitation system and the sexual inhibition system. Or you could think of them more accurately as the gas pedal and the brake pedal. The sexual inhibition system is your brain telling you all of the reasons that it is not a good time to get turned on right now. Perhaps your grandmother is standing there. Perhaps you are running and being chased by a lion. Terrible time to get turned on when you're being chased by a lion. Your body needs to be allocating those resources to other things. And we know that trauma brain suggests that our brains identify things that remind us of being chased by a lion that may not resemble at all being chased by a lion, but they feel like that in our bodies. And so that all kicks on the sexual inhibition system, the brakes. It hits the brakes. Stress, being hungry, having pain, any of those things are going to hit the brakes. The sexual excitation system, the gas, the juice, the awesomeness, is all of the sexually relevant stimuli in your field of awareness. That doesn't necessarily mean it has to turn you on. It's just something that your brain's like, oh, we sexualize breasts in this society. So you see breasts and there's a part of your brain that's like, that's sexual, noted. You see someone that you're really attracted to and your brain's like, that's sexual, noted. And it starts to build up that awareness of those things that are turning you on. Now the problem is, if the brakes are on, it doesn't matter how much gas you have, you're still not gonna go anywhere. And so the process of getting turned on is turning off the offs and turning on the ons. You have to lift the brake pedal in order to hit the gas. And that's where cannabis comes in. Cannabis can help you address the things that are getting in the way of pleasure, connection, and intimacy. Things like pain, stress, anxiety, pain with penetration, chronic pain, headache, any of those kinds of pain-related items can all impact whether or not you feel like having sex. And it's really useful to be able to have a conversation with your patient and be like, hey, so maybe we're in a medical state. Have you ever tried cannabis? What does that look like for you? Do you use it? Oh, you do, great. How do you use it? How do you decide what products to use? Because people come to me all the time as the canisexual, and they're like, what's the best strain for sex? Anybody want to know what's the best strain for sex? Yeah. Whatever works for you. You're asking the wrong question when you ask what the best strain is, because there's a couple of variables that you have to keep in mind. One is that strain names, super varied by region and dispensary and grower. Like, they all have different cannabinoid and terpene profiles. Y'all have heard about cannabinoids and terpenes all day. You know that it varies a lot. Indica and sativa, gosh, that is just not even remotely an indicator of effects. Not even a little. It does not tell you, like, people are like, oh yeah, sativa's for like creative, like hyper, energetic sex, and indica's for that like slow, sensual sex. And I'm like, nope, that doesn't work. Because the piece of the puzzle is the person. You have to consider the person and the context in which they are enjoying whatever cannabis product they're using, what their tolerance is like, what their body chemistry is like, where they are in their cycle. All of those things are going to impact, in addition to the sexual inhibition and the sexual excitation systems. There's a lot of factors. And so when patients come to you and they're like, I heard about this sex and weed thing, how does that all work? You get to give them homework. So Anyone have their phones out right now taking notes? If you go to my website, which is cannasexual.com, CANNASEXUAL, you can sign up for my mailing list, and in that, you will receive a cannabis product and strain tracking template that I created so that people can journal. You have to do the legwork, the clitoral legwork. You have to put in the time to figure out what's going to work for you and your body and your situation. And so when somebody comes to you and they're like, I just got like a gram of, I don't know, Blue Dream, let's say. What do I do? How do I use it? What do I do with it? I don't know. You can say, okay, here's what you're gonna do. You're gonna go on a little fact-finding mission. You are going to masturbate. Yep, you get to tell your patients to masturbate if they ask you about sex and weed. Sure do. Which means you have to get comfortable saying the word masturbate. You can practice it with your friends, practice it with your colleagues. Have like discussion nights where you all sit around and talk about sex, because you have to do it to get better at it, to feel more comfortable with it. You know, how many people would feel comfortable having a conversation about masturbation with their patient right now? More than I would have thought. That's pretty rad. Go you. Round of applause for that. That's impressive. And for those of you who aren't immediately comfortable with it, there's nothing wrong with you. You're not broken. You're not a bad nurse by any means. You just have to practice. But masturbation is where it all comes down, because when you introduce another person, that's a whole other body's worth of variables that you have to figure out how those two things are interacting. And so when couples are like, we want to do sex and weed, how does that work? Starts with masturbating. You take a little of whatever it is that you're using, whether you're doing, I don't recommend edibles for sex unless you are a seasoned cannabis user. As one of the previous speakers said, like inhalation is the easiest way to titrate dosages, to be really specific in how much you're using. Edibles are just such a wild card because they're not uniformly produced, they're not uniformly, even within like the package itself, let's say it's a brownie, they might not be a homogeneous mixture, and so one corner could get you really high, and one corner could like, you don't feel anything. And it takes 2 hours to kick in. And most of my clients have about 10 minutes for sex, because they work, and they have kids, and life's really busy, and who the fuck has time for things, sorry. Who has time for this stuff? And so, but masturbation, that's a lot easier to figure out because you can make time for it on your own, and you create a scene. Have time where you light some candles, light some incense, put on something sexy, like make a date with yourself, because most people are socialized to experience pleasure quickly and silently. We grow up like rubbing one out real quick while our parents are asleep in the next room as quickly as possible, so you just like come and go to sleep. Anybody else? Right, it's real. And so we're not used to expressing ourselves. We're not used to taking our time and really exploring our bodies. And that's what you have to do when you're employing cannabis, because you have to figure out what the cannabis is doing to your body, and the best way to do that is to masturbate. So whether you're applying a THC or CBD infused topical to the vulva, which is actually a really great place to do it, the exposed mucosa make it very absorbent for the cannabinoids. It takes about 20 to 30 minutes to kick in. And as someone who is a sexual assault survivor who experienced pain with penetration from the age of 13 until the age of about 28, and I thought I was broken and I thought things were wrong with me, turns out cannabis oil, THC oil, actually made the difference where I was able to experience penetrative sex without pain. That was huge. And so you have to try it, whether you're doing topicals, whether you're doing inhalables, whether you're doing tinctures, although I just learned something today that oil-based tinctures aren't as absorbent under the tongue as we thought. That's good to know. I love this conference. I'm learning things all the time. But masturbating is so important. So you try whatever it is that you're trying, you give it the time to kick in so you start to feel the effects, and then you notice, am I more tactile? Am I more orgasmic? Am I more responsive? Am I more vocal? Or am I totally distracted and I just want to watch Netflix for 3 hours? Because if that's the case, that may not be the date night strain for you. So really considering and encouraging people to be their own fact finders is so important as nursing professionals. You have such a powerful, amazing opportunity to let people know that they get to decide what their sex life looks like, and it doesn't have to look like anyone else's on the planet. It's just theirs. And it doesn't have to look the same every time, and they don't have to be in the mood for the same things every time. And if you use cannabis really mindfully and you start thinking about what's getting in the way, what's coming up for me, like what would I need to change to feel more sexual? Oh gosh, wow, I'm really in my head, like I need something that's gonna get me out of my head and into my body. Oh, geez, I found that thing last week that I tried, and it actually really was good at getting me out of my head. Let me reach for that. That's where we want people to get to when it comes to cannabis and intimacy, where they're being very intentional about the products that they're putting in their bodies. And it's not just, all right, let's get stoned and bone and see how it goes. No, no, no. That's a recipe for disappointment. Be really deliberate with the choices that you make about your body and your sexuality, and create context. Don't just, toss all the clothes on the bed and get to it, unless that's your jam. But if you're somebody who's really type A and laundry on the floor is gonna distract you, make time to clean that up first so that you're in a space where you can feel sexy. The brain responds to context. Tickling is a great example of this. When you're like with your special someone and like maybe they tickle you a little bit and you're like, oh, hee hee, that's so cute. As opposed to when you're in the middle of a fight with them and they try to tickle you and you're like, I'm gonna punch you in the face. Context matters. Any questions as I get toward the end? I only have a little bit of time left. Yes.
I wanted to know exactly which one of those you were talking about putting on the vulva, which oil. I mean, some of them have menthol in them and...
Yes, so, okay. I tend to be of the less is more variety. There are a lot of really terrible lubes on the market, like just regular lubes that aren't THC infused, and then some of the THC lubes add a lot of things that they don't need. I tend to be purist, less is more, coconut oil, THC oil, maybe some CBD, and like that's really all you need. Menthol is just gonna make it tingle. It's like icy hot on your genitals. Like, if that's your jam, cool. If not, not so much. I don't wanna give you a specific product recommendation because as this is a continuing education environment, I can't give you an actual brand, but if you see me afterward, I would be happy to point you in the right direction because I do work with some pretty amazing companies. The other last little piece I wanna tell you is lube. Please, please, please tell your patients to use lube. It's so, like regular lube, not even cannabis-infused lube, just regular lube. It's not just for people who are postmenopausal. It's not just for people who aren't getting turned on as much, because now we know that wetness and arousal are not always correlated, only in 10% of cases. But lube is so crucial. It's great for hand jobs, it's great for blowjobs, it's great for genital massage. It's great. But there's ingredients in it that are really harmful and damaging, like glycerin and parabens and these really irritating substances that you find in grocery store lubes. So have them do their research and like actually find good quality lube companies, and if you need recommendations, please come see me. I do work with nurses and medical professionals generally. If you want more of a deep dive, if you have specific questions about maybe things your patients have brought to you, but come see me, check out my website, canasexual.com. Thank you so much for being here with me for this. Go masturbate!
Sex, cacao, cannabis, yoga, massage. We heard about sex yesterday. Should we bring Ashley back up? Ancient healers have been using cannabis for centuries. All of these foods and herbs have a synergistic effect when consumed together. After all, we are choosing to use cannabis as our medicine. Shouldn't we maximize all the benefits of this beautiful plant?
As cannabis nurses, we have a duty to bridge the knowledge gap for these patients by ensuring they understand what constitutes medical quality cannabis. I'm honored to be here today amongst so many fellow cannabis nurse warriors. I hope you will all join me in educating and advocating to ensure our medical cannabis industry evolves in a patient-focused manner. Thank you.
I realized at that moment that I had a responsibility to help patients get safe access. Many of my patients don't want to smoke it, they don't want to get high. But what I decided to do was to treat cannabis medicine like any other treatment modality. If you want to build an army right now, get the seniors on your side. Get them off their pharmaceuticals. They will write to their legislators. They'll be active in their community, and they will help us move this forward.
Hello, good morning. Is everybody awake? Sex, cacao, cannabis, yoga, massage. We heard about sex yesterday. Should we bring Ashley back up? That was a great combo yesterday. Well, my name is Gina Lucero, and I'm a registered nurse. I'm from Albuquerque, New Mexico. I've been a nurse for 8 years. My nursing experience is with dementia, Alzheimer's, joint replacement, and pain management. But I specialize in cannabinoid therapy. All potential conflicts have been resolved. You're right, we did talk about sex yesterday. And today we are going to open up the discussion on endocannabinoid system care. What can we do to help balance out our endocannabinoid system? What activities can we do to balance out and implement into our daily routines? Which foods enhance the endocannabinoid system? And hopefully today you will leave here with some new knowledge and an urge to go out and obtain homeostasis. Exercise, meditation, yoga, social interaction, massage, sex, intimacy. We all talked about this yesterday. We learned some fascinating information. But exercise, we are all guilty of being too busy. But 30 minutes of low-impact exercise can help your endocannabinoid system. It helps to improve circulation, it produces adrenaline, endorphins. Meditation, yoga have been used for centuries combined with cannabis, as we learned yesterday. Have you ever paid attention to where your chakras are located? It's an interesting find from your core down to the center of your being, right where your CB1 receptors are located. Ancient healers have been using cannabis for centuries. We talked about that yesterday, but it's taking science for us to prove that it's actual medicine. Ancient healers have been combining yoga, meditation, and cannabis, and based off of their physical results when the two are combined. The same concept goes for balancing your mind, body, and spirit. Social interactions, being around people we like, positive energy feeds the soul and stimulates our receptors. Massage, personal touch. Our skin is loaded with CB2 receptors. When we get a massage, it sends signals to our receptors telling your body that it feels good. Combine that with the cannabis topical, whoa, now we're really stimulating our receptors. Sex, yes, we talked about it yesterday. And do I need to say any more on it? Yes, it helps to balance us. Research shows that women that are ovulating actually have an overabundance of anandamide. When we're on our menses, we're depleted of anandamide. Our own bliss molecule. What happens to women when they're PMSing? That's right, we get tired, cranky, irritable, but what do we crave? Chocolate. Cacao is actually loaded with anandamide. Our body tells us what we need, when we need it. We just don't listen to it. We use echinacea all the time to help us when we are sick. It aids in relief of arthritis. It's used to fight fatigue and migraines. Why? Because it helps to build up our immune system. How? Cannabimetics. These are compounds that are not exactly similar to cannabinoids, but they interact with our endocannabinoid system, especially the CB2 receptors. It activates our endocannabinoid receptors, just like herbs high in beta-caryophyllene. Clove, rosemary, basil, hops, oregano, black pepper, copaiba, lavender, cinnamon, electric daisy. Have any of you used electric daisy? It's used as a toothache plant. It has a grassy taste, but I do have to caution you when you use electric daisy because it does leave a tingling sensation. It will leave you with a tingly throat, but excessive salivation. So maybe don't use electric daisy before social interactions like sex or intimacy. Helichrysum. This is an amazing plant, and it also contains cannabinoids CBGA and CBG. It's an amazing anti-inflammatory. Research suggests that Helichrysum also has some psychotropic qualities similar to cannabis, and of course, cannabis. We all know that cannabis mirrors our own endocannabinoid system. And when consumed on a regular basis, it will aid in helping our endocannabinoid system to regulate and bring us homeostasis or balance. All of these foods and herbs have a synergistic effect when consumed together. After all, we are choosing to use cannabis as our medicine. Shouldn't we maximize all the benefits of this beautiful plant? So now I encourage you to go out and medicate, fornicate, and create love and peace.
A question I get quite a bit is, Eloise, how did you get into this? And I have many defining moments, but the one moment I want to share right now was a moment when I was working as I wasn't working yet, I was becoming a nurse practitioner, and I was doing my clinical hours in an oncology setting. And I had a newly diagnosed lymphoma patient. She was 82 years old, and she was about to embark on a highly emetogenic regimen. We expected her to have some severe nausea and vomiting. And when I was meeting with her and going over her chemotherapy regimen and discussing side effects, she looked at me and said, "I'd really like to try marijuana for my nausea." And I said, "Oh, I think that's a great idea. Let me go discuss it with the physician." And I went to the physician, and the physician said, "Absolutely not." And I was really confused. She's a fall risk, okay? So I walked back to the patient and I said, "I'm really sorry," but the physician said no. And she looked me straight in the face, as serious can be, and she said, "That's okay. I'll go out in the street and I'll get it." And I went, "No, you won't." And I realized at that moment that I had a responsibility to help patients get safe access. And I gave her safe access, knowing that I could be jeopardizing my clinical rotation as a result of it. And after that, I became known as the nurse at the facility who would talk to you about cannabis, and people started bringing in bags of stuff and asking me to evaluate it. I left that job. They offered me a job at the end, and I said, "I think there's a need out there to help people navigate through cannabis as a medicine." And he said, "You're going to be a drug pusher?" And I said, "Isn't that what we do here?" And he said, "Touché." So since then, I've now treated over 5,000 patients. I did discuss this yesterday. You know, many of my patients don't want to smoke it. They don't want to get high. But what I decided to do was to treat cannabis medicine like any other treatment modality. So when patients come in to see me, I do a very thorough intake. I take this very seriously. I review their medical records. I look at their test results, their exams, their list of medications, their allergies. I go through their health history, their treatment history, their comorbidities, their cannabis use. Have you used it? What did you try? What was your experience? Are you at risk for substance abuse? And because most of the people I work with are seniors, you can see here that they struggle with age-related changes. They have balance issues, visual issues, hearing issues, clearly visual issues because they think my picture's my daughter, and they think my husband is my son. He's got more gray hair than me. And so they come in with very consistent complaints, right? They suffer from lifelong decisions that were poor decisions. So they have chronic pain, sleep, anxiety, depression, loss of appetite, high blood pressure. And maybe they drank too much, or they're still drinking too much. Maybe they smoked, they didn't exercise. We got to hear about how important it is to upregulate and maintain our endocannabinoid system. And this is years of not doing that. We didn't know then how important it was. They also are susceptible to unique risks. There are some scooters around here in San Diego. Drug reactions, inappropriate medications, cost, packaging. I mean, nobody wants the kids to get it. Can we all know that we're all on board with that? But now guess who can't get into their medicine? Seniors, right? They come in frantic. Or they call me up, Eloise, I took a hammer to my package to get it open. Did you ruin your package? Did you ruin the product? Nope. All right, well, I guess that's what it takes. But then they have barriers, right? They have a really hard time getting consistent inhale, and they have a specific chemovar or chemotype they found. They go back and it's gone. They have healthcare professionals that won't legally advise them about where to go and what to get. They have a hard time finding a qualified healthcare professional. And when they do find someone, they're afraid to tell their clinicians that they're using cannabis. And so in my work, I try really hard to empower my patients. I tell them the more you know and understand this plant, the more you can help yourself and the less you're going to rely on me. I am a self-paid. They don't get any insurance reimbursement from me. So the more, it's a terrible business model because people don't come back to me when I get them independent. But the more they understand, the more they can help themselves. And so I do a lot of education around the different cannabinoids and terpene profiles and what I think will help them the most. And of course, because it can have these biphasic properties, I really encourage them to start low and slow, and that's not just a low amount, but it's slow titration, waiting 3 days, maybe 5 days, waiting 2 weeks before we reevaluate, maybe even a month. It's not a silver bullet. And because edibles can be so varied in terms of onset, in some of my patients, it's taken them up to 4 hours to actually feel the effects of an edible. I typically do try to avoid those, and I like to work with the drops or the tinctures. Because if they have a bad experience, what happens? Yeah, they never do it again, right? And now they reefer madness, and marijuana's bad. And so an average dose in the dispensary is about 10 milligrams, maybe 5. In my patients, I'll typically start them between 1 and 3 milligrams. It's a great starting dose. It really gives them a chance to get acclimated to it without side effects. Remember, don't confuse psychoactivity with efficacy. And again, these are some of the routes that we try to offer them. And what I tell patients is, it may not work right away, but look at all the options we have. 80% of the time, I can get somebody relief and help them get off their medicines and onto cannabis as their only treatment. But they have to be patient. We have to set expectations with them. And I just want to end with this. I read an article by a physician who had put out a call to companies and saying, you're missing the market. You should be marketing to seniors. They have a lot of money, and they use a lot of medications, and we're missing the boat. And I was so angry. I was so angry, because my patient population, they don't have a lot of money. They're on fixed incomes. But we do need to market to this community because they vote, and they are our best advocates. And if you want to build an army right now, get the seniors on your side. Get them off their pharmaceuticals. They will write to their legislators. They'll be active in their community, and they will help us move this forward.
My cannabis nursing started back in 2012 when I experienced the profound healing of the sacred plant as a cannabis patient myself. Cannabis helped me wean off the pharmaceuticals I was dependent upon for immune support and pain relief, while facilitating deeper levels of healing than thought possible. A couple of years into my own health recovery, cannabis also eased my teen daughter's extreme symptoms of autism puberty crisis, the severity of which was putting her at risk of out-of-home placement due to the safety issues caused by her self-injury, aggression towards others, and property-damaging behaviors. Thankfully, intervening with cannabis successfully eased her symptoms while also improving her quality of life and overall function. These are my cannabis passion makers. I feel like my life has come full circle, and now I'm blessed to utilize the knowledge gained through those personal experiences to educate patients and guide them in optimizing their medical cannabis therapy outcomes. My priority working with patients is taking an individualized approach, including thorough assessment of their considerations and a targeted care plan. I also began writing blogs, which led to being published in nationwide cannabis industry magazines. And I'm an educator for medical professionals like yourselves, both theory courses and clinical immersion to learn application of cannabis therapy. Please know I do not currently benefit from the sales of any cannabis products and do not harbor any profit bias. The most common area of patient confusion is regarding what constitutes medical-grade cannabis. For the first time, a patient may be overwhelmed by the product choices, and bud tender advice isn't always reliable. As cannabis nurses, we have a duty to bridge the knowledge gap for these patients by ensuring they understand what constitutes medical quality cannabis. So, to help fix this issue, we created the flow criteria to educate cannabis patients on the research-supported criteria for optimal cannabis formulations to ensure they access medical quality cannabis products. Flower-derived because we know the most potent raw material for extracting the full spectrum of plant components is the cannabis flower. Trichomes in the flower produce the cannabinoid and terpene content, and the flower also contains the highest concentration of synergistic plant components. Lab testing is the only way to verify product contents, potency, and rule out contaminants. Being a grower myself, I know how easily plant tags can get swapped, and we simply can't rely on strain names to verify a product's profile. While organic certification of cannabis doesn't yet exist, many growers advertise organically grown, and labs help to verify that a product is free of any contaminants or harmful toxin residuals. This is especially important when working with already sick patients who have heightened susceptibility to toxic exposure. Whole plant means concentrating cannabis as nature intended without isolating or removing any of the plant components, which is supported by research for offering the strongest entourage effect, or which is what we want when we're targeting that homeostasis that cannabis can provide. Any given cannabis plant contains a unique profile that may include hundreds of therapeutic compounds, including cannabinoids, terpenes, bioflavonoids, antioxidants, chlorophyll, and essential fatty acids. In a 2018 meta-analysis by Pamplona, the response of whole plant versus isolate cannabis for seizure management was explored, and it was found that whole plant was as or more effective than isolate at only 20 to 25% of the isolate dose. Unfortunately, pharmaceutical companies are capitalizing on cannabis isolate with products like Epidiolex, which is less effective at higher dosing and costs 20 times that of a custom whole plant blend for seizures. Another study completed in 2015 by Galilee concluded that isolate cannabis, with or without added terpenes like we see in CO2 extracted products, exerts a bell curve response. By recording TNFA, Galilee found that isolate CBD's anti-inflammatory response peaked and then subsequently dropped off as isolate CBD dose was increased, reflecting a narrow margin of therapeutic dose. Conversely, the whole plant formulation in Galilee's study exerted increased anti-inflammatory response congruent with whole plant CBD dose increases, which supports that whole plant has a more reliable mechanism of action versus isolate. If you're interested in learning more, I detailed the research and rationale for the flow criteria in my article, Evaluated Cannabis Products for Safe, Effective Medical Use, published by Cannabis Nurses Media in January of 2019. As nurses trailblazing a new specialty, there's a lot of gray area to maneuver. We are bound by licensure requiring our patient education to be evidence-based. Since most cannabis research is completed on isolated components of cannabis instead of the whole plant, this hampers our knowledge of standardized titration ranges, thereby supporting our current cannabis nursing approach of teaching patients to start low and go slow. I truly believe that cannabis has the capacity to revolutionize our healthcare industry, and keeping our medical cannabis paradigm patient-focused is integral to the potential becoming a reality. As cannabis nurses, we are at the forefront of this revolution, and our advocacy and expertise will help to shape the future of medical cannabis. I urge every one of you to educate the flow criteria to patients and advocate for more whole plant research so we may one day have evidence-based dosing parameters to guide patients in their use of optimal medical formulations of cannabis. I'm honored to be here today amongst so many fellow cannabis nurse warriors, educating the truth about cannabis to the masses. I hope you will all join me in educating and advocating to ensure our medical cannabis industry evolves in a patient-focused manner. Thank you.
What does it mean to be euphoric? What does it mean to be high? How do you discuss that with patients?
We were talking about euphoria and the word high. To me, as a professional cannabis nurse, we need to come up with different verbiage, because with our seniors, one of the very first things I hear from my seniors is, I don't want to get high. It's like it's this bad term. Same thing with euphoric. Euphoric almost sounds like a exaggeration of feeling good, and the loss of control, I believe, is what's at the root of it all. So I challenge you in a way is there a way that we can make a different type of verbiage when we're speaking to our patients so that they understand that it's a alteration in your mind, but it's not losing control? What do you think, Eloise?
So Dawn brings up the point, I think it's a challenge for all of us in the room to be using terminology that is descriptive and helpful and not old drug war style scare tactic. And does the word high really represent what can occur with plant medicine or with cannabis as medication? Thanks. And these are all things we'd love to hear from you as well. Yeah, please.
Thank you, Dawn. That's a great question. The first thing I'll say to my patients is, what does it mean to get high? I want them to tell me in their own words, and it's generally, well, I don't want to hallucinate and I don't want to lose control. And then from there, I can have the conversation about, well, some forms of cannabis may be impairing. You may feel like a drunken sailor if you overconsume THC, or losing some of your cognition, your faculties. If I describe to them that euphoria can help them be more relaxed and more communicative with their spouse and more patient with their family members and more enjoyable to be around, they generally will open up to the thought of euphoria, and their family members definitely open up to it.
Right? Definitely. Yeah.
And usually it's the family members when they come back in that say, oh, I don't know what you're giving them, but they are a much nicer person to be around.
Right.
And they'll kind of look at their spouse like, I am, So yeah, it really is about changing the terminology, the vernacular. Mm-hmm.
Thank you. Next question.
Hi, we're from the middle table, and we all talked about preparing your own herbal remedies and helping patients learn how to prepare things to empower them, empower their caregivers, and there are lots of things that can be done. And in the interest of full disclosure, I am A, a senior, and B, have smoked grass since the 70s. And I haven't been addicted to anything ever, and I have no idea. I come from Georgia where very little is legal, and probably never will be. But through a series of events, I have an ability to make candies for my patients that does have THC in it. And I'll bring it to the chemo suite because they're made out of little Jell-O candies. And this lovely young lady here makes a salve for pain. So we've all kind of dipped into our creativity. And what I tell my patients is, I want to give you something that will help you take back control of your own spirit while you're getting chemo. You don't have to sit there and look at this red or yellow or whatever noxious thing is dripping into your port or your arm and feel like a victim. And being euphoric merely means that you can take your thoughts to a place that's very pleasant to you, like the beach, like the forest, wherever, and enjoy yourself and feel a sense of self instead of a sense of being a victim.
We're going to throw out discussion topics to you throughout the day. If you know, your table mates are going to give you some intel, but keep these conversations moving into the day and the night. We have about 6 minutes. What are your questions specifically for our panelists? We welcome your questions. Are you miking for a question?
Can I say something?
Yes. Yes. Well, initially, what I was going to mention was how important it is to ask the patient what high means to them as a way, like Eloise was mentioning, as a way to sort of open up that conversation. There is a popular theme at our table of feeling incapacitated or feeling out of control. But one of us mentioned couch lock as a feeling of that's what high might be, and another felt just maybe it's hallucinating, that's what high is. So it's really targeting what it is the patient's looking for and also looking to avoid. But my question is, as far as dosing goes, we know that it's not always just like weight-based when it comes to cannabis. There's a lot of different factors, including metabolism, particularly in older population. When your metabolism changes, what do you identify as key factors in a patient's medical history for risk screening our patients to see if it might be an appropriate treatment option for them?
The question is about how to make recommendations or suggestions or coaching for
Right.
dosing based on a patient's medical history.
Right.
Well, I start off by discovery, asking questions. What are they trying to accomplish? What's their goal? Are they trying to get off of pharmaceuticals completely? Are they trying to complement the pharmaceuticals that they're on? I deal with a lot of pediatric and older patients. So initially with our CBD regimens, we do it off of weight, and we do their body weight in pounds, and it's a fourth. So 0.25 times their body weight will give us like a starting point for a CBD regimen. And then you can incorporate the THC as they can tolerate it. I'm a huge fan of microdosing. And so starting off small and lower doses, consistent doses for maybe a month before we start titrating them up. But a lot of the factors that we do really have to consider are the medications that they're taking, because there are a lot of pharmaceuticals that do interact with the P450 enzyme, and you want to make sure that we're not over-medicating their pharmaceutical on their cannabis regimen. But I always ask discovery questions, and you really need to know what the goal is first, and then you can build a regimen around that.
I'd also like to add, and then we've got, definitely have 2 more questions, is that small is a really relative word. For me, a small amount is the entire pint of Ben & Jerry's. And
Yes.
so we really want to be specific with what
Yes.
small is and microdosing. And I know we saw a slide yesterday that had microdosing at like 0.25 or something, but I wonder if we could define that as the smallest amount that achieves the desired medicinal wellness effect the patient is looking for. What is microdosing?
Microdosing is starting small, like 1 milligram, a half a milligram. Just, you need, especially if they're brand new and they're a novice to cannabis, you don't want to start them off on a 5 milligram edible. They'll have a horrible dysphoria situation going on, and they'll never do cannabis again, or it'll take them a long time. So you want to start off small. I mean, 1 milligram of THC, see how they do for a couple of days before you start increasing it. Now, cancer patients, in order to treat cancer effectively, they need large amounts of THC, but you can't just start giving them 50 milligrams of THC and expect them to be fine with that. They'll get sick. And you have to outweigh the pros and cons of the side effects. If they're taking so much THC that their endocannabinoid system is shutting down and they're getting nauseated and vomiting, then it's too much, and you need to back down their THC content a little bit and see what they can tolerate.
Great. Eileen, your question?
Yeah, and I definitely agree with that, Gina. I would just add that, it's super important to look at the individual's targets and teach patients what the risk factors are of cannabis therapy. And we do know that it would take a perfect storm scenario to cause patient harm, but it is possible. Cannabis has been used 5,000 years, cultures around the world, no deaths ever. The curveball today is the pharmaceutical interactions, especially with high dosing. We could put patients at risk, and I've seen some near misses from patients that walk into a dispensary with their card, and an 80-plus-year-old patient with chronic pain, dispensary the first time, she got a 300 milligram THC candy bar. But thankfully, the bud tender told her to only eat half. And this patient was on metoprolol, which has interactions with THC. So, it could have been, we've seen some near misses. And really, in the interest of not only protecting patients, but protecting the reputation of cannabis, we need to be educating patients on that piece.
Absolutely.
Yeah.
Thank you.
We have time for a final question, and our experts will be here all day to answer your other questions. Eileen?
So when it comes to doing patient education and patient dosing, how do you deal with out-of-state patients?
With what patients?
Out-of-state patients that you're not licensed. Like, what do you do if you're not? I've done it before. I worked outside of my scope of practice and standards. I don't do that anymore.
Yeah.
So
the question's about being a coach or a guide to people that may not be living in a medicinal state.
Or even the state where you're licensed to work in. So what do you do? Eloise?
I was advised not to give advice outside of my state, so I don't advise out of my state. But people have had different, you guys want to touch on that? Because I think you can go to many different people and get many different opinions, but I practice within the state of California only.
Yeah, and I think as a nurse practitioner, there's actually legislation that commands that for you, correct?
It's a nursing thing, it's not an NP thing.
Okay.
Yeah.
We do educate patients regardless of their location. We don't advise dosing, so that's a big piece. I think when you start giving numbers to patients, that's where you're pushing that scope, because some states see cannabis as prescriptive, so that becomes the doctor's responsibility. But it supports the low and slow titration. Patients need to know where to start. They need to know, not to go and purchase 50 milligrams and take it all at once. So we do educate that piece. In most of our work, we're targeting symptom management. And so we just say start low and increase slowly, and when you feel better, stop. So that tends to be the approach that we take. And we do have, terms of service. We explain to patients it's education, it's not medical advice, and also have a waiver so patients agree to our terms of service stating that they understand, because of the specialty nature of this knowledge, that the nurse they speak with may not be licensed in their state. We also have nurses on staff that have compact licenses, which covers more states than just one. That covers 30 some odd states. Yeah. So there are ways to kind of work around it a little bit, and it just, you have to ask what's your individual comfort level. And in my case, from an integrity standpoint, I can't turn away these patients knowing that my education could really help benefit their health. So.
In New Mexico, we have to be very careful about using the word dose. So we do serving recommendations. We have a serving recommendation sheet that we'll put the information on. And as far as working with patients outside of the state, I utilize our network. I mean, look how many nurses are in here. You need to find out which nurses are in which state and refer those patients in those states to a cannabis nurse that can help them there. If you don't have a nurse in that particular state that the patient or the client is in, then I would encourage them to maybe look for resources or have them look at the American Cannabis Nurses Association or the Cannabis Nurses Network and see if they can find a nurse that is local that could help them. But we don't ever turn away people based off of where they live, but we'll try to guide them and give advice as much as we can, because I believe that access to the medicine is the most important.
Yes. The topic is plant medicine, exploring cannabis potentials, and each of our experts is going to give their final thought.
My final thoughts are, I'm glad to see so many nurses and other professionals here interested in this topic, and I hope that you feel a little bit more comfortable and confident in how you can move forward in this industry. And thanks to CNN for highlighting this and putting it together. I know it's a lot of work, and I'm grateful to be here. Thank you.
And I kind of said my final thing already too, but just would really encourage you all to an important thing in my career has been having really great mentors, like Eloise is one of them, and Heather, and just having a supportive group of nurses, because all of us are new in this. Nobody knows everything. We're still learning. The research is still emerging. And, this is really going to be powerful to stay on top of it, because in a decade, what we know now is going to pale in comparison. So having nurses you can bounce ideas off of, or, hey, I have this hard patient, or, if you have a patient that is, they have a disease that you're not used to working with, find nurses that specialize in these different areas and collaborate. And, we've formed some brain trust, and, we've learned so much from one another. So really, this is such a great venue for that, for networking and meeting other nurses, and it's just been so important in my own journey. So I encourage all of you to do that.
Thanks. Gina?
I want to say thank you. I attended one of the first Cannabis Nurses conferences about 4 years ago, and I was just sitting in the audience, just mesmerized. I just couldn't believe that these wonderful women were up here advocating. And they steered me, guided me, mentored me. They've become amazing friends. And I encourage you all to bond with everybody in this room, because it's going to take numbers. It's going to take a village to bring access to this beautiful plant. And we can't do it alone. And if anybody is here thinking that they can move mountains by themselves, you're terribly mistaken. It takes a village, and it takes a wonderful community of medical professionals like ourselves to be heard. We're advocates for a reason, not just for pharmaceuticals and for patient care. We're advocates for autonomy, because everybody deserves autonomy to their health care.
Some appreciation for our first panel. Thank you.